So it's a pleasure to be here, thanks. Has been I'm going to summarize the first two sessions on prevention and diagnosis. There has been a lot of interesting things, and I'm sure I'm going to miss things, and hopefully not too many. If I had to say, I have to choose one that was very impressive to me, was that we learned this morning that the ducks are being transformed in rabbits. What is something I didn't know, and makes a lot of sense because we see that technology, data, and computing are really transforming many areas of science, society, and obviously medicine. This is a fundamental change. I think was very well argued this morning in the fantastic keynote talk, and was also a second question to that, are we ready for this digital transformation? And I think this is something I'm not completely sure about, and I think it's worth keeping this in mind. My conclusion from that, and I think it's the most important one and a very obvious one, is that IMI has to be an actor in this digital revolution, cannot be in any other way. The question for me is not if we have to do it, if we have to be an actor in this revolution, is what are the specific goals and how we do it, but not that we have to do it. So my conclusions are very simple. I think I have 6 main points. We see this technological, the first one is that this technological and biological number of digital gadgets are still in a very early phase of developments. Indeed, it's just the first generation of gadgets. Most of them, and this was already argued this morning, has not been developed for medical applications. We are, in a sense, abusing the technology for other applications. So I guess the obvious conclusion from that is that we need to do specific developments, and IMI has to put efforts in making specific developments on disease-specific tools, gadgets, technology. And to do that, we need standards for developing this technology. Otherwise, with guidelines and standards, will be difficult for developers and will be even more difficult for the users and for the health systems. My second conclusion is about data. It's very obvious that we have very large volumes of complex data, and this data is very heterogeneous. These make us, as life science, as medicine, very different of other areas of science, physics, and the others. On top of that, our data has this private character and are, in many cases, difficult to access for legal, technical reasons. All the issues related with ownership, privacy of the data, and economical value of the data are building a complicated issue, and we have to work on that. There are plenty of European projects dealing with different aspects of data access, data harmonization, federation of data. From my point of view, IMI should not enter into doing one more of these projects, should try to find ways of coordinating these activities and driving them to specific applications. What I mean is by finding the value of the applications of the access of this data and building infrastructure to connect these many different sources of data, more than competing with the many projects that are already providing technical means to access and exploit the data. There was a very interesting discussion, and I think this is my third point, about evaluating technologies and benchmarking technology. Benchmarking is essential for the development of science and for the development of industry. Benchmarking implies making accessible environments, data set, tools, and making these accessible and open in a way that the developers and the companies can know how to evaluate the tools and the methods and the gadgets. The users, including the clinicians, the doctors, the hospitals, the people or the patients, can know what is the technology that is working and how this is working. The discussion this morning, and I think it's a very interesting one, is what will be the role of the regulators. The regulator has been, until now, reactive to the technology. In this case, we see the need of the regulators to be proactive. And this is an interesting transition. So, assuming that we understand the importance of benchmarking, that is necessary to develop standards, to move communities in a specific direction, and to help in this transition of the developments to the clinic, I think it's very clear that IMI has to have a role in the evaluation of technologies and benchmarking of technologies. My fourth conclusion is that if there is something that we need are longitudinal data set with deep phenotyping, and this is including samples and biobanks that will be ready for the new technologies, because we know very well that whatever we do now will be overcome by new technologies in a few years, so we need to keep records and of the samples for the future technologies. All this has to be organized in a way that we can also not only do longitudinal studies, but we can also do continuous recording. And there has been a number of arguments why continuous recording is essential for medicine. And this has to be linked to the medical information, whatever these are, electronic records, other sources of information, web or self-reported data sets. Linking the phenotypic and the samples and in the longitudinal studies and making them accessible is essential. Obviously, there are many projects doing different project initiative, country-wide or European-wide initiative. The 1 million genomes was already mentioned this morning and can be one more of these initiatives. So I don't think that the IMI has to be necessarily doing one more of these longitudinal studies. That is probably not something very proper for IMI, but certainly can contribute to the creation of standards, annotations, and federation models to be able to access these already existing very large repositories, and certainly can provide systems to make data accessible for specific applications. An ecosystem of applications that will run on the data that is organized in different countries, hospitals, projects, will be really something very productive, more than developing new ones. In this context of longitudinal studies, the arguments about healthy brain as part of healthy everything, I think is a very interesting one and a very powerful one. Healthy brain can be seen as part of healthy life, healthy individuals, healthy environments, and why not healthy healthcare systems. The proposal in this case will be to transform or to do some of these large cohorts in normal individuals, in healthy individuals. We need background information. This background information has been essential for any of the large studies that has produced interesting results. So I can imagine projects around building cohorts of healthy individuals, maybe taking from already cohorts of disease cases and analyzing what makes a healthy individual or a healthy brain in this case. My last issue, my sixth conclusion, will be about a very general scientific subject, that is how we relate the genetic and environmental causes with the consequences on disease, causes and consequences. In this case, we are analyzing, and much of the discussion today was about symptoms. We have to move from symptoms to the causes, whatever these are environmental or molecular, microbiome or human genome, if we want really to make progress, not only in diagnosis, but also in the treatment of diseases. If we don't understand the generation of the diseases, we will only be treating the consequences of the diseases. Again, the role of IMI, like many other European projects, linking genotypes, phenotypes, causes and consequences, I think is still a very much needed area of action. So these are my 6 points around need to develop technology, need to use the data and to profit from the data, providing access to cohorts and being able to analyze large longitudinal cohorts, and continue the struggle for understanding the causes of diseases at the genotypic level, but also at the environmental level. Thank you.
Thank you very much, Afonso.